So welcome to today's target session on overprescribing. My name is Heather Smith. I'm a consultant pharmacist for older people and I'm based at the ICB in Leeds. So what we're going to cover today is what is overprescribing, why does it matter, what are the causes, how we're doing in Leeds, so sharing some of the data, how do we balance the risks and benefits of medicines and discussing these with people, what training and resources are out there that can support, what might help, and what can you do? So what is overprescribing? It's just the use of a medicine where there's a better non-medicine alternative or that use is inappropriate for the person's circumstances, values and wishes. And there was a national overprescribing review commissioned and they produced this report that came out in September 2021. So why should I care about overprescribing? So first and foremost, medicines do a lot of good and nobody prescribes medicines wanting to do harm. We actually want to help people. So I'm sure we've all seen people like this lady in this picture who's very glum about the number of medicines that she takes. So sometimes people's lives fit around their medicines rather than the other way around. And sometimes people are taking medicines that they don't want to take, and sometimes medicines cause harm. So this paper from last year found that adverse drug reactions or side effects cause or contribute to 16.5% of medical admissions to hospital. Why should I care? Workload. So I'm sure we've all got too many things to do and not enough time to do them in. And last year, between January 2022 and January 2023, we issued around 25 million prescription items in Leeds, and that number seems to be increasing. What about the environment? So about 25% of the carbon footprint of the NHS is due to medicines, and every time a patient takes a dose, between 30% and 100% of that dose ends up going into our toilets, and it's not removed by our sewage system, so it's being found in aquatic life and in the food chain. And about 5% of pharmaceutical pollution is caused just by patients flushing their medicines either down the sink or down the toilet. This picture is from NHS Highland and it shows 3 months medicines waste waiting to be incinerated. And NHS Highland has a population of 320,000, so it's much smaller than Leeds. So in Leeds, we probably have more medicines that are going to waste than this. And then why should I care? Well, system. So in terms of the monetary value of medicines waste, so it's thought to be about 1 in every £25. So that was from a report in 2010. And then 10% of medicines are thought to be overprescribed from the overprescribing review. So in 2022-23 in Leeds, we spent £137 million on prescribed medicines just in primary care. So overprescribing in Leeds is thought to cost somewhere between £5.5 and £13.7 million just in primary care. So why does overprescribing happen? Well, overprescribing is complex and multifactorial, but these are just some of the reasons on this slide. So multiple prescribers, particularly if they're just prescribing in their area of expertise or in a small area, and if it's not joined up. Lack of shared records and documentations of decisions or changes that we're making to medicines, not involving people in decisions as much as they'd like, dealing with the symptoms rather than the causes of symptoms, using medicines when non-medicines options might be better, and patients themselves not knowing who to ask if they've got concerns about their medicines or not feeling confident to raise issues. And then people and their wishes may change, but their medicines don't. So what suits us when we're in our 50s might not suit us when we're in our 80s. And then we also have single condition guidelines, which tend to be based on evidence in patients without multiple conditions or on lots of medicines. And there's also a lack of guidance around stopping or tapering medicines as well. And all of this is complicated by a lack of time because we've all got too much work to do in the system. So there is a national programme from the Academic Health Science Network around polypharmacy, and it's called Getting the Balance Right. So what we're doing is trying to support the Academic Health Science Network with this work rather than duplicating what they're doing. So this is based on 3 pillars. So one is around population health management, and they're using the NHS Business Services Authority data to try and understand which patients are at risk within PCNs and GP practices, and prioritising patients for medication reviews. Pillar 2 is around education and training, so they're running local polypharmacy action learning sets. And the idea behind these is to upskill the primary care workforce to be more confident about stopping unnecessary medicines. And there's been really good feedback from people who've been on those training courses. And pillar 3 is around public behaviour change. So it's around public facing campaigns to try and get people to ask questions about their medicines. So in Yorkshire and Humber, we're using the Me and My Medicines campaign, which came from a member of the public in Leeds. And again, it's just around encouraging people to ask questions about their medicines. So there are a number of AHSM polypharmacy events, so I've just given you the links if you want to join any of those. So there's a number of cohorts for the action learning sets. So these are for GPs and anybody who's been prescribing for more than a year in primary care. And there's also a 5-minute video that explains what those action learning sets cover. There's a community of practice. So the next one is on the 20th of September, and I appreciate if you're joining a late target session, this will be after that time, but there will be other community of practice around polypharmacy coming up later in the year. So please contact Graham Finney if you want to join any of those. There's also training about the polypharmacy dashboard and how to use it, and there's also a recording of previous training. And then the Yorkshire and Humber AHSN are also supporting local polypharmacy masterclasses. And the first one will be on anticholinergic burden on the 11th of October. So there's a link to join that if you're interested. So in terms of the polypharmacy dashboard data, this comes from the EPAT2 data from the Business Services Authority. So this is data around medicines that have actually been dispensed rather than just prescribed. And as you can see, there's a number of different prescribing comparators that you can search on. And you can also get that data down to patient level data if you've got the IG clearance from your practice. So let's look at the Leeds overall data. So SICBL just stands for sub-ICB location, so it just means place. So this graph is showing you where Leeds is in relation to all the other places in England. So the data is just for Leeds as a whole. So there is quite a bit of variation between different PCNs and different practices in these comparators. And we have shared a snapshot of the data with your PCN pharmacy teams for each PCN and each GP practice. So this is looking at the percentage of patients prescribed 10 or more unique medicines who are aged 65 and over, and you can see that Leeds as a whole is just above the national average. There's a similar picture for 10 or more medicines in people aged 75 and over. In terms of people with an anticholinergic burden score of 6 or more, so this is a high score, which I'll explain a bit more about later. You can see Leeds is pretty much bang on the national average there, and a little bit above the average for patients prescribed 2 medicines with moderate to high anticholinergic burden. And then finally, looking at high oral morphine equivalent volume of opioids, again, Leeds is just above the national average. So I'm also the lead for West Yorkshire on overprescribing. So from a West Yorkshire point of view, we've set up some task and finish groups. So they are around structured medication reviews, anticholinergic burden and opioids. And some common themes have come out from those task and finish groups. So we've got a lot of resources, but it's where we keep those repositories and where we can host them, where they're accessible to everybody that needs to know where they are. There's also education and training, so not just for healthcare professionals, but also for members of the public. Something's come out around directory of services and signposting to non-medical support. So we're lucky in Leeds in that we do have a directory of services, but some other places don't. And then issues around transfer of care have also come up. So we're doing some specific work at the moment, and this will be shared across Leeds when it's completed. So we're looking at a resource to explain what is a structured medication review. We're also looking at patient preparation and participation resources for structured medication reviews. We're writing some guidance around anticholinergic burden and patient information on that topic. There's going to be a West Yorkshire Medicines Waste campaign, and that's going to be focused on the environmental impact of medicines. We're working on a West Yorkshire Overprescribing website, and we hope to host the resources and education and training opportunities on there. I've already mentioned the polypharmacy masterclasses, and we're also looking to improve transfer of care, information and follow-up, particularly between secondary care and primary care. So when we're looking at prescribing and deprescribing, what we really need to do is balance the risks and benefits for individuals. So at the top, we're thinking about what matters to the person. So what are their individual goals? It might be looking at quality of life rather than quantity of life, depending on the person's wishes. So on one side, we've got the benefits of treatment. We've got things like life expectancy and the person's personal aims. And the things that can help us there might be things like numbers needed to treat, which I'll explain in a moment. We need to think about making targets appropriate to the individual. So we might need to loosen targets, for example, for blood pressure in an older person living with frailty. And we also need to think about whether the person can actually manage to take their medicines properly. So do they need any support, or do we need to help them have those right behaviours for taking their medicines? And then on the flip side, we've got the harms of medicines, adverse drug reactions or side effects, and risks of treatment, and also that burden of treatment. So things that we can look at there might be the numbers needed to harm. We can also think about the impact on their daily lives. So can they manage that medication regimen, particularly if it's complicated? Are they at risk of things like overdoses and interactions? And do we need to help them with that? So we might need to think about the complexity of the regimen and whether the patient's on any potentially inappropriate medicines. And we have tools that can help us identify that. And if all of this, we need to be aware of maintaining the status quo. So this study, the Newcastle 85 plus study, found that in patients who were 85 years and were followed over 11 years, they found that each additional medicine led to a 3% increase in mortality. So I've already mentioned number needed to treat and harm. So what is that? So the number needed to treat gives you an idea of the level of effect for an individual patient. And of course, we need to consider if the outcome is meaningful to the person. So we also need to think about what period does that benefit occur over. So for an older person living with frailty, for example, we'd need to compare that to the life expectancy. So an ideal medicine would have a number needed to treat of 1, i.e. it would help everyone who took it. And unfortunately, we don't have medicines that have a number needed to treat of 1. So the higher the number needed to treat, the lower the likelihood of effectiveness. And a good sort of rule of thumb is that a number needed to treat of 25 over a year would be considered to have significant benefits for individuals. And the number needed to harm just gives us an idea of the level of harm or the number of side effects that we might expect for an individual. And we also need to remember that data from clinical trials, which the number needed to treat and the number needed to harm are based on, are usually trials with younger people who don't have lots of things wrong with them and aren't living with frailty. And for information on number needed to treat, there are a few resources. So you can obtain them from the Scottish Polypharmacy Guidance. There's also the NICE database of treatment effects spreadsheet. So if you Google that, you can download the spreadsheet. And there's also GP evidence and MedStopper. So how do we talk to patients about the benefits and risks of treatments? Well, this acronym BRAN comes from the Choosing Wisely website. So BRAN stands for B for benefits, R for risks, and a court judgment reminds us that we need to not tell everybody about every single risk, but remember to tell them about the risks that they would consider important or significant. So basically tailoring what we tell patients to what they want to know in order to make a decision. Then we need to speak to them about A for alternatives, and also to cover N for doing nothing. So there are some shared decision making resources and tools that might help. So we've got the AQUA Ask 3 questions. So what are the patient's options? What are their pros and cons? And do they need any support to make the decision that's right for them? Then we've got the GROW model, which is a coaching model. So what is the patient's goal or aim? What is the reality? So what's going on now? What are their options? And W stands for will. So what action will they take? I've mentioned Me and My Medicines, which can help people or encourage people to ask questions about their medicines. And then there's some good training available on e-learning through the Personal Care Institute. So it's free to register with them. And there's a couple of training modules. One is 30 minutes on shared decision making, and there's a 15-minute training module on Teachback. So I've mentioned anticholinergic burden before. So what is it, and why do we worry about it? So many medicines have anticholinergic properties, and they cause side effects that you may be familiar with, such as blurred vision, dry mouth, and constipation. In older people, they cause additional adverse events such as confusion, dizziness, and falls, and they can often impact on a person's function or their ability to carry out their activities of daily living. And although it's not proven that they increase mortality, there's a definite association in the literature. You can use calculators to work out the anticholinergic burden, and an anticholinergic burden score of 3 or more is associated with an increased cognitive impairment and mortality, but it's a guide, not an absolute rule. So it's just information to help you have discussions with patients about the medicines that they're on. And there are a couple of calculators to work out the anticholinergic burden, and these are the two that are most commonly used in our area, so the ACB calculator and MediCheck. So deprescribing, what is deprescribing? So deprescribing is really just stopping medicines, although some definitions also include reducing the medicine or tapering it. And these are my two favourite quotes around deprescribing. So Doug Darforth said, starting medicines is like the bliss of marriage, and stopping them is like the agony of divorce. So we all know it's a lot easier to start a medicine than to stop one. And Steve Williams said, if we just keep on adding and never subtracting medicines, we will just multiply the problems. So there's a couple of really helpful resources here. So there's the Scottish Polypharmacy Guidance. It's also available as an app that you can download onto your smartphone. And in it includes the 7 steps to appropriate polypharmacy. So this is just a process to help you review people's medicines. And then we've also got MedStopper. So MedStopper is a Canadian resource, so you just need to remember that when you're using it. So you can't use paracetamol because they call it acetaminophen. But it's very helpful because it traffic lights the medicines in terms of risk. So red being high and green being low. It also tells you whether the medicine is helpful in terms of long-term benefit or symptom control. And it also gives you information on if you need to taper the medicine rather than just stopping it completely. And the Canadians have also produced this 3-minute video, so this might be helpful for any clinicians who are struggling with deprescribing in their day-to-day practice, because it covers how to overcome some of the barriers to deprescribing. So moving on to language of prescribing and deprescribing, the language that we use when we talk to patients about prescribing and deprescribing really is important in terms of managing patient expectations and future expectations. So one of my personal bugbears is when people use the term lifelong medicines when they're starting treatment, because when I come along 20 years plus later and start talking to patients about how their medicines may no longer be appropriate for them or doing them benefit, it makes it really difficult when someone said, you need to take this medicines for life. So it's much better if we use the term longer term. So for example, when we're talking about anticoagulants for atrial fibrillation, as with anything, use simple language and check back on understanding. Try and avoid terms like painkillers, because the person might then expect all their pain to be removed. That's unrealistic in older people, for example. So pain relievers is a better term to use. And whenever I'm talking to somebody about stopping medicines, I always use the term trial without. In the States, they use the term pause and monitor, but it's the same principle. So this is less frightening to people, and also shows that you're going to follow them up to see how they're getting on without their medicine. I also use the word trial when I'm starting medicines and advise that we'll stop if there's no benefit or if there's side effects. And another of my bugbears is around asking patients if medicines are actually providing benefits rather than are you okay on this. So side effects are not always obvious to the person. So for example, the cognitive side effects of anticholinergics or an impact on blood pressure from an antidepressant. So we did carry out a survey across West Yorkshire around structured medication reviews. So this was mainly pharmacy staff who answered this, and these are a snapshot of the results from Leeds. So one of the things that came out was that colleagues didn't feel that other people that they worked with understood what a structured medication review was. So a structured medication review is a comprehensive and clinical review of a patient's medicines and detailed aspects of their health. And we do it by facilitating shared decision-making conversation with the patient, and it's aimed at ensuring that their medicines are working well for them. And it takes a long time, so the average time required is about 30 minutes, particularly if somebody is complex in terms of having a lot of things wrong with them and taking a lot of medicines. So this slide is around the Taylor medication synthesis. So this was led by Professor Joanne Reeve. So she's a GP, but also Professor of Primary Care at Hull and York Medical School and the University of Hull. So what they did was a realist review around what works, what helps in terms of deprescribing in primary care. So they found that deprescribing was safe, effective and acceptable if done in a structured way, but no single approach was identified as best. And what they found in terms of how we do tailored prescribing, so they found that when healthcare professionals feel that they can't make justifiable decisions because the guidelines don't support them, then they're reluctant to make changes to medicines because they're worried about the negative consequences. When they don't have time, they might be less likely to make changes to patients' medicines because they don't have the emotional cognitive capacity to consider complex issues. And when patients and their carers or family are asked to change their usual medicines by somebody who they don't know, they may be reluctant because they're concerned that that person doesn't know what's best for them personally. And they also found that when healthcare professionals know they're able to follow up a patient, they're more likely to try deprescribing because they're reassured that they can manage potential harms. So what does all this mean for you? So there's absolutely permission to do structured tailored deprescribing, but you don't have to do this on your own. So use the multidisciplinary team who are around you. There's also permission to flag this as a problem if you don't feel like you can tackle it yourself, and also to explore learning resources for your own professional development. So there's a link there if you want to find out more about the Taylor medication synthesis, and there's also a link around some knowledge resources around the Taylor synthesis as well. So finally, what can you or your team do to reduce overprescribing? So if you're a prescriber, when you're prescribing, use shared decision making, the BRANG acronym. Think about your language and ask yourself, what outcome am I trying to achieve, and does it matter to the person that I'm prescribing for? Support, deliver or refer patients on for structured medication review, and use the Older People's Medicines Queries Advice and Guidance Service if you need help, support or advice, and that's available via AccuMail. For all staff in primary care, look out for people who might be having problems with their medicines. Support patient campaigns such as Me and My Medicines. And if you don't know who that is in the picture, that's Graham Presswich. So he's the author of Me and My Medicines, and that's us at the British Geriatric Society after he did a really good speech there. And again, refer on for structured medication reviews, for example, to your PCN pharmacy teams if you feel people need a full review of their medicines. If you're conducting structured medication reviews yourself or long-term condition reviews, understand the person's perspective and goals, so what matters to them. What does the research evidence say? So think about numbers needed to treat and numbers needed to harm. balance the risks and benefits as much as possible using available tools, resources and common sense. So particularly when you're thinking about longer term benefits for people with limited prognosis. Think you might need to be pragmatic. So what can the person actually manage rather than what are all the medicines that I'd like them to take? And beware of maintaining the status quo. So risks might not be apparent until it's too late. Again, if you need any help, support or advice, use the Older People's Medicines Advice and Guidance Service. Thank you very much for listening. If you want to get in touch, my email address is heather.smith11@nhs.net.